So this is again a very simplified, way to show you the entire glycogen metabolism. I have already explained this, that this is very simple, that glucose is converted to glucose 6 phosphate into glucose 1 phosphate into UDP glucose, and with branching glycogen synthase and branching enzyme is converted to glycogen. This glycogen, with the help of debranching enzyme, is broken down into glucose 1 phosphate into glucose 6 phosphate into glucose, and via GLUT2 receptor it comes out. And there is a very minor mechanism where glycogen is directly broken to glucose with the help of acid maltase. Okay, so let's look at various glycogen storage disorder. The first glycogen storage disorder which we are going to see, this is also called as type 0, is basically when the glycogen synthase is absent. So basically it's not, in this case the glycogen will not be formed. Just as a conceptually, type 0 is when glycogen synthase is absent and no glycogen is basically stored. So again, it's a storage disorder basically. But here, the amount of glycogen will be less. Okay. Now, having said that, let's look at the first, true glycogen storage disorder where the increased amount of glycogen will be stored. So that is basically called as von Gerke's, okay, or type 1A disease. In this, glucose 6 phosphatase will be absent. So what will happen? This glucose 6 phosphatase was important for conversion of glucose 6 phosphate into glucose. Okay. Now because this conversion is inhibited, there will be increased amount of glucose 6 phosphate. And what will this increased amount of glucose phosphate do? This will activate glycogen synthase. And once the glycogen synthase is activated, all this glucose 6 phosphate will be converted into glycogen. So even though the glucose level is falling down, but glycogen synthesis is stimulated. Very interesting, right? Right. So first thing we see is there is a increased glycogen deposit, okay, in both liver and other kidney or spleen, wherever the glycogen is stored. So this is number one. Now interestingly, if you see this step, conversion of glucose 6 phosphate to glucose is common to both gluconeogenesis and glycogen breakdown. Both these mechanisms are very important to allow, disallow fall of glucose in your body, fall of glucose body. Both these mechanisms have now been wiped out because of a single step. Okay, this step, if this step is not working, both these mechanisms have been wiped out. So in this case, the children will present with severe hypoglycemia. Severe hypoglycemia. Okay, very low blood. And generally they will present very early in age. Within the first month, they will start presenting. Another very important thing, they will present with features of chronic hypoglycemia. Chronic hypoglycemia, which means the blood glucose level, because it is going to be falling for a very long time. What are the features? So in chronic hypoglycemia, there will be, because this hypoglycemia, what it will do, it will increase the glucagon. Okay, and this glucagon will activate hormone sensitive lipase. And what will this hormone sensitive lipase do? It will break down triacylglycerol into free fatty acid and glycerol. So there will be increased in free fatty acid level of the body. There will be hypertriglyceridemia, or increased in free fatty acid level of the body. So this is the third feature. Next, if you see, next very important feature is that gluconeogenesis is inhibited. So, pyruvate cannot be converted into glucose. Pyruvate cannot be converted into glucose. So this pyruvate will go into formation of lactic acid. Okay, it will take another pathway. So it will form lactic acid. So this is the only glycogen storage disorder which will present with lactic acidosis. So in any clinical case, if you see lactic acidosis, you can be very sure we are talking about von Gerke's disease. So this is again. Next, if you see, there is a huge increase in glucose 6 phosphate level, and glycolysis already is going to be saturated. So where will all this glucose 6 phosphate go? This will go into hexose monophosphate shunt, the next important minor metabolic pathway or next oxidative pathway available to glucose 6 phosphate. And what will happen with all this glucose 6 phosphate going into hexose monophosphate shunt? A lot of ribose sugar will be formed. And what will happen because of the increased formation of ribose sugar? Lot of nucleic acid synthesis will happen. And whenever purines are broken down, because purines cannot be stored, so because there is an increased formation of purines, there will be increased destruction of purine, and what it will lead to, the next characteristic, that is your hyperuricemia. Okay, hyperuricemia. uricemia. So these are the characteristics of von Gerke's disease. You have 1b where the translocase, what enzyme is absent, which means the enzyme which moves glucose 6-phosphate into the endoplasmic reticulum. That is 1b. So 1a and 1b, hope you are clear. The next disease is called as Pompey's disease. Okay. Now before I talk about Pompey's disease, this is type 2 glycogen storage disorder. Acid maltase is absent, and what will happen? In this case, Pompey's disease is a generalized glycogen storage disorder. Some amount of glycogen, majorly the glycogen is stored in muscle and liver, but some amount of glycogen synthesis and breakdown happens in almost most of the, skeletal muscle, cardiac tissue, liver, and a lot of other tissues also. So in all those tissues, glycogen will start accumulating, and there the major mechanism of breakdown is basically acid maltase. So these, Pompey's disease is a generalized generalized glycogen storage disorder. Generalized glycogen storage disorder. Okay. So this is very, very interesting. I'll tell you, remember this code 2 plus 5 is equals to 7. Okay. So these are the only three glycogen storage disorders which are non-hepatic. Okay. 2 we have seen is generalized, and 5 and 7, both of these are muscular. So when we are going to see about muscular glycogen storage disorder, I'll tell you. But remember this code: 2 plus 5 is equal to 7. So 2 is generalized, 5 and 7 are muscular, and all the other glycogen storage disorders are going to be hepatic glycogen storage disorder. So Pompey's, as I've told you, it will be a generalized glycogen storage disorder. So glycogen will be deposited in the cardiac tissue, in the skeletal muscle, in the liver, and all the other tissues. Primarily, such children will suffer because of the glycogen which is stored in the cardiac tissue. So these children will present very early, around 4 to 6 months, with cardiomegaly and all failures, cardiac failure symptoms. So, and generally, not if not treated, they will die before 2 years of age. Now we have got enzyme therapies which are now available for Pompey's disorder, enzyme replacement therapies which are now available for Pompey's disease. So this is about Pompey's disease. This is a generalized glycogen storage disorder presenting with your cardiac symptoms, cardiomegaly, ventricular hypertrophy in a very young child, somewhere around 4 to 6 months, and generally if not treated well, the child will die within first 2 years of life. So this is Pompey's disease. Now the next set of disorder is basically when the branching and the debranching enzyme is deficient. So before we understand, I'll tell you another mnemonic. And this mnemonic is, now in all the glycogen storage disorder you are going to study, the normal glycogen will be stored. These are the only two conditions where abnormal glycogen is stored. Rest all the glycogen storage disorder, either you have studied about von Gerke's, you're going to study about Pompey's, and all the other glycogen storage we are going to study. In all of them, the glycogen which is stored is normal in character. Only increased amount of normal glycogen is stored. Here, there is an abnormal glycogen which is going to be stored. So let me tell you a mnemonic. This mnemonic is very simple. A, B, C, D, E, and F. Okay. B stands for branching enzyme deficiency, and branching enzyme deficiency leads to Anderson disorder. DE stands for debranching enzyme deficiency, and this will lead to Cory's or Forbes disorder. Very easy to understand. This is Cory's and Forbes is, type 3, and Anderson's is type 4. Okay. So what will happen, let's say, when the branching enzyme is not there? If the branching enzyme is not there, only long chain glycogen will be formed. So because the debranching is not happening, very long chain glycogen will be formed. Very long chain glycogen will be formed. Okay. So obviously this is a hepatic, because I've told you there are only three non-hepatic. So this will present with minor hypoglycemia, some amount of hypoglycemia. But the major problem is this long chain glycogen, they are abnormal. They activate the autoimmunity, which will lead to attack of the liver cells by the autoimmunity, and ultimately leading to liver cirrhosis. So this is Anderson. When we talk about debranching enzyme, so in this case what will happen, the debranching enzyme is not there. So what we will have in Cory's, is a highly branched glycogen, very, very highly branched glycogen. And Again, that highly branched glycogen also is not very effective. So again, you will have some amount of hypoglycemia, and this highly branched glycogen is called as limit dextrins. Limit dextrins. So there will be increased amount of highly branched glycogen which is stored in Forbes or Coris disorder. So this is your type 3 and type 4. Let's look at type 5 and type 6. In type 5 and type 6, only one enzyme is absent, that is glycogen phosphorylase. Glycogen phosphorylase. Now, depending upon which tissue it is, it gets its name. So if we see, type 4 is called as Her's disease. The type 5 is called as McArdle's disease. McArdle's disease, if you see M for McArdle's, M for muscle. So when in muscle glycogen phosphorylase is absent, you will have McArdle's disease. And when liver, or hepatic tissue, when glycogen phosphorylase is absent, you will have Her's disease. So H for hepatic tissue and M for, muscle. So M for McArdle's and H for Her's. So this is how you will remember type 5 and type 6. Now, as I told you, when it is presenting, the deficiencies in liver, there will be a partial deficiency. There cannot be a complete deficiency. So what will happen? The glycogen breakdown will be inhibited because this phosphorylase is the main enzyme which will break down the glycogen. So it will present with hypoglycemia and all. But in muscle, there is very interesting. This McArdle's disease, when it presents, the primary symptom will be that whenever the person is trying to do some physical activity or exercise, suddenly he will start having cramps. Okay, here it is very important to understand that, when you talk about muscle contraction, the first, 2 to 7 seconds will be by ATP. Okay, then up to 30 seconds will be by, this ATP is, recharged, because it is going to be converted into ATP by creatinine phosphate. This creatinine phosphate will recharge the ATP until 30 seconds. These two are there. Then your glucose starts, glycogen will start be broken down into glucose, which will act as a source of energy. It is at this stage, because the glycogen is not going to be broken down into glucose, what will happen? Your muscle will suddenly have a reduction in the ATP, and suddenly it will not be able to contract, and you will have muscle cramps. Eventually what will happen is, this muscle, blood vessels will dilate and alternate, from other places the glucose will start rushing in into the muscle. Okay, the blood glucose will start rushing into muscle. So for the for just, if the person continues exercising, suddenly, after some time he will be able to exercise. So this is called as the, first wind phenomenon, that the person if he will have, when he starts exercising, he will experience muscle cramps and will not be able to do the exercise. But if he continues, he will start be able to do it. So this is your McArdle's disease, presenting generally with cramps when a person tries to exercise. But that cramps or, muscle pain, if he continues, if he pushes himself to exercise for 3-4 minutes, then those cramps disappear. Okay, so this is McArdle's, or one of the muscular glycogen disorder. So this is type 5 and type 6. Type 7 is basically Tourette disorder or phosphofructokinase deficiency. Now this again happens in the muscle. Okay, this again happens in the muscle. So first, let's understand why Tourette disorder will present as a glycogen storage disorder. So you remember that basically, what is the function of phosphofructokinase? Fructose 6 phosphate is converted into fructose 1,6 biphosphate. Okay, so if this is, slowed down, what will happen? All these fructose 6 phosphate will get converted into glucose 6 phosphate, and this we know will stimulate glycogen synthesis. So that is why this Tourette will present as glycogen storage disorder. That's number one. But the characteristic difference between McArdle's and Tourette is two. Number one, in Tourette, the symptom will come only after, the person has taken meal. So normally he may not have so much of muscle cramps during exercise. Okay, but if, he has the meal, then the symptom will be aggravated. And the logic is very simple, because once he will have the meal, there will be increased glucose level. So what will happen? There will be increased fructose 6 phosphate level. So then, he will have more symptom. And second, because here if you see, the glycolysis itself is challenged. Okay, so here, even though the person, if he starts having cramps after meal when he's trying to exercise, if he continues to do the exercise, still he will not be able to do, because here the breakdown of glucose is only, challenged. The source of energy for muscle contraction itself is challenged. So he will not be able to even, so like in Mac adults, he was able to exercise after some time. Okay, if he continued to exercise even besides the cramps, he was able to start exercising once his muscle vasodilation happened and glucose from the circulation start entering into the muscle. But here, even if the glucose enters into the muscle, he will not be able to, because that glucose will not be broken down into you know pyruvate. The energy will not be released. So this is how you will differentiate Mac adults with Tories. Two, one, Tories will present muscle cramps with food, after food. Okay, and second, in Tories the cramp will never relieve even if the person continues to exercise, whereas in Mac adults, after some time the cramps will be relieved and the person will be able to exercise. So this is type 7. The last type is type 8, that is called as Fanconi-Bichet syndrome, which is basically the GLUT2 receptors are absent. Okay, GLUT2 receptors are absent, and this primarily will have all the symptoms of von Gerke's. Okay, the only difference is that here type 2 receptors, GLUT2 receptors will be absent, but the symptoms will be very, very similar to von Gerke's disease. So this is all the glycogen storage disorders in short. So let's quickly look at and revise all the glycogen storage disorder and what are the important points which are asked. So von Gerke's I've already explained. So remember, first of all, it's an autosomal recessive disorder. There's an increased glycogen production and decreased breakdown. There's a progressive hepatosplenomegaly. There will be severe hypoglycemia because not only glycogen breakdown but gluconeogenesis is also impaired. There will be hyperlipidemia because fat mobilization is increased due to chronic hypoglycemia. There will be lactic acidosis. This is very, very characteristic. And when you get a clinical case, if you see lactic acidosis in a glycogen storage disorder, you simply know that is it von Gerke's. Present very early, in 3 to 4 months of age. And these children, because of this, hyperlipidemia and fat mobilization, will present with doll-like faces, short stature, thin extremities. Okay, and I've told you 1A is von Gerke's, 1B is when glucose 6 translocase is absent. When we talk about other hepatic, so hepatic von Gerke's we have seen there is Cory's, Hers, and Anderson's. Okay, type 3, 5 and 6. So Cory's, the debranching enzyme is absent. So debranching enzyme, so limit dextrin, and it will present with mild hypoglycemia and hepatomegaly. Hers, type 6, when glycogen phosphorylase is absent in liver, mild hypoglycemia with hepatomegaly. Anderson's, long chain glycogen, because the branching enzyme is absent. Okay, hepatosplenomegaly, and because mild hypoglycemia will be there, but because this glycogen is abnormal, it will invite the autoimmunity, and ultimately the liver will undergo cirrhosis. So this is about Anderson's. When we talk about myopathic, there are two myopathic, Mac adults and Tauris, that is type 5 and type 7. Mac adults, basically the phosphorylase is absent in the muscle. There is no liver symptoms, so no hepatomegaly, no hypoglycemia. What will it present with? Muscle fatigue, weakness, and cannot do strenuous exercises, and rhabdomyolysis will present with rhabdomyolysis and myoglobinuria. But remember, in Mac adult disease, if the person continues to exercise, after 3-4 minutes when the vasodilation will happen, he can continue doing his exercise. Next is Tories, muscle phosphofructokinase is here, and weakness during exercise, especially after a meal. Okay, and remember, in this, the weakness after the meal will not subside even if the person is continuing to exercise. Okay, so this is about the myopathic. The last is your POMS disorder, which is basically the generalized or type 2 glycogen storage disorder. The defect is in acid maltase. There's an accumulation of liver, glycogen in liver, cardiac, skeletal tissue, smooth muscle. So it's basically generalized, and death is generally by cardiac failure by 2 years of age, and enzyme replacement therapy is available for Pompe's disease. Last thing, in most of the glycogen storage disorder, it is managed by dietary. So what is the diet which you give for most of this glycogen storage disorder? If you see most of this glycogen storage disorder, especially von Gerke's and all, there the problem is that the glucose level should not high, and the glucose level should be given over a sustained period of time. So uncooked cornstarch, because uncooked cornstarch, the characteristic is it takes very long time to digest, and it will keep releasing slow and steady release of glucose. So because there is a slow and steady release of glucose, what will happen is the blood glucose level will not very fall down, so there will be literally no hypoglycemia, or very and the blood glucose level will not go very high also. So if it does not go a very high, even the glycogen synthesis will not happen. So uncooked cornstarch is one of the major dietary recommendations for many of these glycogen storage disorder, because that uncooked cornstarch really it takes a lot of time to digest, and it keeps releasing slow amount, or steady amount of like glucose throughout. Okay, so neither it will lead to hypoglycemia nor hyperglycemia leading to glycogen synthesis. So these are the management of all the glycogen storage, primarily by your dietary way. So this completes our glycogen synthesis, breakdown, regulation, and storage disorders.